And the second question is, I believe, related to adjuvant treatment. It says, what do you think to give in early stage ROS1 positive lung cancer? Should we use Crizotinib? So I'm going to assume it's asking about adjuvant treatment. What do you do if you have a resected stage 2 non-small cell lung cancer that happens to have ROS1 rearrangement present? And the answer is, at this point, we don't know. There is not information. If you think that the same history with EGFR is going to repeat, and we're going to go back to the ADORA trial that was mentioned earlier in this presentation, maybe that's going to be the way to go. But because of the implications of cost, commitment to a treatment for 2 or 3 years, and potential toxicities, I think we have to wait for formal clinical trials before we make a formal recommendation. But it looks a very attractive idea to do that.
You know, just you had highlighted about the importance of biomarker testing. How do you have reflex testing at your institution? How do you ensure that all your patients have
that's the million-dollar
first-line therapy?
Million-dollar question, Jeff. We just had a tumor board. We have a tumor board with other hospitals participate. And there was a patient who had advanced disease, was on cycle number 4 of chemo. And when I asked what was the molecular information, it was in process. So we came up with a lecture that this is really unacceptable in 2022. You have the option for liquid biopsy, and normally the turnaround time in the worst case scenario is 3 weeks, which is, in my opinion, too long. And that brings the question, should we do reflex testing? And I think in the ideal world, the answer is yes. If I'm a patient that is diagnosed with non-squamous, non-small cell lung cancer, at the time I go see the medical oncologist, I would want them to see all the histologic, all the immunohistochemistry, and the molecular studies, just like our breast cancer patients do when they come see me. We don't need to initiate that, at that time, because that's another 2 or 3 weeks. But I think the main obstacle has been always financial and logistics. But I think we're coming to that point. At least in my hospital, I work in a community hospital. It's a teaching hospital, but it's community. We're going to try to do molecular testing in-house. And I don't know if that's going to facilitate the process. But I think that's very important, because you're really missing out as a patient if you don't do targeted therapy, especially at the beginning of your treatment. If you get on chemotherapy, especially if you're EGFR and you go on chemoimmunotherapy, that's, in my opinion, a disservice to the patient. So,
absolutely. And as you pointed out, people are so quick to, that ROS1 having high PD-L1 status, to focus on the PD-L1 while the genomic information is pending.
And the confusing part is that even though when you read the literature, some of these targetable mutations are associated with a low PD-L1 expression, actually, I see a lot of high expression in some tumors. I've seen actually 100% PD-L1 and EGFR mutation. And sometimes the physician is saying, should I do this or immunotherapy? And if you know the data, there is no question. You don't treat with immunotherapy. Those patients don't respond well to immunotherapy. So yeah, I think correct testing is key in these cases.